Hello, welcome, my friends. I am so excited to be here with you tonight. We are going to be untying. You get it? It's a little bit of a pun, but we're talking about tongue ties, navigating tongue ties for dental professionals, for the dental industry. We are deep diving in, and I'm going to forewarn you some of the stuff I'm going to say is going to be controversial. It's going to be different from some of the things that you have heard. I am very much the opinion that we need to have more people swimming upstream than we need people swimming downstream together. So when you're listening to me, you're definitely going to hear something that's different from what everybody else is thinking. And I think that's the better way for us all to be, honestly. That's how we grow as a unit and as a field, as a profession. We have to continue to challenge the boundaries. It cannot innovate when we're all in that same bubble. Okay. So first, let me know that you're here. Let me get in the comments any hellos. Give me a good hi. Give me a hey, I'm here. Hey, I'm so glad to see you. Hey. Oh, good. I'm very excited that you guys are on. Okay. So this slide I think is so cute. It's like we don't know what all the fuss is about. There's a whole lot of controversy, a lot of chaos that has been brought up. Chaos seems like the perfect and the right word to essentially bring out that, yes, we've got a lot going on in the industry. The challenge of the public kind of pushing back against tongue ties, I think is really, really interesting. And some people think that it's very detrimental. I think that it's actually a great moment for functional providers to shine, a great moment for dentistry to pivot the narrative, because the narrative there was supposed to be like a money hungry type of situation. And we didn't pivot appropriately. There's a lot that went wrong that we can really dive into. Hopefully, if we have some time at the end, my controversial opinions, everybody enjoys that. And there's a lot of fuss about a lot of things because you think it's just the tongue tie. Ankyloglossia has been around forever. Everybody knows how to identify ankyloglossia. Tongue tethered to the tip. It is like lack of mobility to the greatest extremes. You can't stick your tongue out. And then that is a simple snip, right? Periodontists do it, oral surgeons do it, ENTs do it with like a little bit of local anesthesia, just choop, that's it. And then there's no need. Like, what's all the hype? What's all the fuss? Why is everybody getting these 70, 80, 90, $100,000 laser machines to do this thing that has been around for centuries, that a lot of people know, and they know from within the confines of how they learned it within the dental program or within their further specialty learning and education. What's all the big fuss? Well, the big fuss is that there's a lot of conversation as to why we are releasing tongue ties, right? So that I think that's where we need to focus first, okay? Why we're releasing tongue ties. Because when we see things that come out like this in the New York Times, and we want to immediately jump to like, oh, what terrible journalism. They didn't do their research. They're not knowledgeable. I can't believe they're trying to push this narrative yet again, because trust and believe, if you think that that was the first, the third, or even the seventh time that tongue ties and the dental profession, and whether or not it's overdiagnosed or just something for people to make more money off of, that is absolutely not the case. It's been around for years. They've been writing about it since 2016, 2018. You had the Huff Post, like the Daily Telegraph. You've got all of the major, the Atlantic, I mean, everywhere that they could write about it, they're writing about it. The New York Times, that was their third. It's contested, but possibly fourth. There's one article that may or may not count because it wasn't necessarily a pro or a con. It was just more informational. But that's their third time writing about it and writing about it in the negative. It's an absolute PR nightmare. And I really think that the number one thing this field needs out of everything is public relations. Like, stop sharing each other's stuff, start sharing PR information. You got to stop talking to the public if you don't know exactly what it is that you're talking about. Now, That's not to say that you don't know what you're doing as a therapist, as a dentist, as a body worker, as a IBCLC. You very well know what you're doing. You're working off of a lot of information that is mostly clinical and some of it's based in research. But all of these articles are very consistent about one major truth that we all like to gleefully ignore, just like hop right on over and ignore. It's that we don't actually have any sort of ground to stand on when it comes to research. There is no standardized classification system. You know why there's no standardized classification system for tongue ties? No, not because nobody's created one. Several people have researched and tried to create one and validate and this, that, and the other. The inter-rater reliability, it is completely up for whoever wants to take a stab at assuming what this is. So what you think is 50%, what I think is 50%, or what I measure as this and what you measure as that, and what tooth I use, and then how wide we're getting them to open. Is it their actual maximum opening or is it their comfortable opening? What if they have something that's limiting their opening? So now they can't open because they've got TMD, and then that's going to affect the number that we're going to get. And so that's going to change my inter-rater reliability versus your inter-rater reliability because we're looking at two different things and lots of different perspectives. And it was the big thing that made everything kind of fall apart when it came time for the whole floor of mouth conversation. So the floor of mouth conversation that wound up being something else. We wanted to have a standardized classification system about that. But then there's the argument that a frenum is literally the floor of the mouth to the base of the tongue. So if you limit the floor of the mouth, of course you're going to have limit on the base of the tongue. Like the tongue will not be able to achieve the same range. Like you're just duplicating essentially what's happening with the tether. You're not showing anything. And then there's the other side of the argument that says, okay, well, there's a difference before and after, but all of it is completely subject to whatever it is that you actually can substantiate as a provider, right? So there's no standardized system for classification. So you could write that off right there. Okay. So any sort of research, validation, you want to go tell this journalist that they're terribly wrong because there's so much great quality research. Well, no, there's actually no long-term studies. Like we don't know what the implications are. We talk about tongue ties. We talk about them from biblical times. We talk about them in midwives. They used to use their finger and so forth. That's actually not something that we're quoting from like these long-term studies that are like, okay, so these people who have had their tongue tie released when they were infants, now that they're 80, here's how life has been. Here's what we've noticed and changed. Here's what's the trend. Here is our other subjects. So we have subjects that were a part of it and we have subjects that weren't a part of it. And we followed both of them over long-term studies. And we don't have that. Or what about the large sample size? We are a global entity of about 7.5, 8 billion. It depends on who you're asking. But when you look at 8 billion, and then if you just look at America, let's just go back to America, about a little over 300 million people in America. So 300 million people in America, right? The biggest studies we have on tongue ties, particularly with this whole functional airway perspective wrapped around it, it only includes less than 400 people, the biggest studies. Then we have a lot of, short clinical studies and so forth. And that's not really enough to substantiate to say that, oh, yes, this is something that it was replicable and it definitely represents the greater portion of the population that is actually getting tongue tie releases. Because while we have some of the research on the prevalence that says, okay, ankyloglossia, whatever you determine that to be, because there's no standardized classification system. So it could just be people tethered to the tip, like with a very severe anterior tie. It could be that it's just, inappropriate number because why is it that I go into homes and I see people almost all the time that have tongue ties? So it's not something that is easy for us to really put a stamp on and to be like, yes, there's so much research behind it. No, the New York Times people were correct. They looked over all of the available research. They took months to put this together. I could have given them that information in probably about the less than 10 minutes that I gave it to you. I mean, it really wasn't worth all of that digging and diving and whatever. And it's not worth contesting because trust me, by the time we hit 2025, if we don't have one or two more articles that are denouncing this field, we're I don't know what's going to happen. I mean, I'm telling you, we're not heading in the correct direction because we're coming at this from the wrong angle. And I'm going to tell you why. There's no direct correlation. It's all a bunch of hypothesis, hypothesis. We're still hypothesizing that the tongue tie and the limited range of motion that affects this and this affects that, and da 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 da. Not everybody that has a tongue tie has dysfunction. And honestly, I'm going to say that I don't care what the tongue looks like. And you're going to get that from me in just a second. I don't care what it looks like. It's how it functions. And so if it's going to be how it functions, then aren't we really having a conversation not about a procedure? We're having conversation about our functional outcomes. So we're having conversations more so about myofunctional therapy. Also, another thing that is not a thing. Okay. Also, another thing, there's not enough research to validate that. There's not enough standardization to even say that we're doing a thing. It's not a thing. Okay. Trust me. Just stick with me. Okay. I promise. I promise. But it's not enough for us to have this lack of correlation to where everybody who now gets a release is supposed to get a magical outcome. So you get the release and then boom, functional outcome. That would be direct correlation. So having enough research to say that tongue tie releases do something functional isn't a valid goal to try to achieve. It doesn't even make sense. So when I go back and I read articles about the tongue tie releases, and there's always these cases of things that went terribly wrong, none of the things that actually went wrong, it's ever stated that the tongue was not released, that the procedure or the surgery went wrong, that the process that they went through in getting that frenum removed or revised didn't happen. It's actually that whatever functional outcomes they were hoping to get, a restoration of a great latch, a restoration of whatever flow of the breast milk, restoration of some functional task, digestion, breathing, proper oral resting posture, achieving adequate speech, oral motor skills. They didn't get that specific outcome. But that outcome doesn't come from having a release. It never does. It's like saying that if I go and I get a scratch off ticket, I'm guaranteed to win. I'm not guaranteed to win. In fact, it is a small chance, a very small minority of a chance that I actually will come out of that as a winner. Doesn't mean that people don't win just because I haven't. Just because my experience didn't work out the way I thought it would. It doesn't mean that people don't win. People still do win. That's just not the common route. So when we're talking about it, we have to realize that there's no direct correlation. So these people aren't wrong, okay? So now that we understand that they're not wrong, that we don't have the research, we don't have two legs to stand on if we're going to try to come at this from like, yes, there's research, or what about all my patients? That's your clinical experience. And that's based on not a tongue tie release. It's based on functional work and functional outcomes, especially if you're referring to, a therapist after you're released and so forth, or they're working with somebody, they're doing manual therapy. It's never just we release the tongue and then boom, everything was wonderful. Okay. So we have to come at this from a different perspective if we're going to have better conversations with our patients, have better outcomes long term for the field, because I guarantee you, if we don't start making a change, we're going to see this field cut down real fast because nobody knows how to react appropriately to bad PR. Nobody. You double down. And instead of doubling down, it's time for us to humble down. Humble down and realize that we need to start having more conversations about function. Once we get to the conversations about function, then yes, we can finally push through. Okay. So let's start talking about what you're looking at when you're looking. For those of you who are not familiar at all with like what's a tongue tie, like that's what you're hoping to get out of this, I'm going to tell you it has to involve two things. Yes, a restrictive frenum, but above and beyond that, dysfunction. So if there's no dysfunction, I don't care what it looks like. I don't care what you see. You could see true ankyloglossia tethered to the tip. You could see this wonderful butterfly clefting in the tongue where it looks like an upside down heart when they protrude or when they elevate the tongue. You could see whatever you want to see. If there's no dysfunction, it is not a tie. That's it. Point blank, put a period on it. Okay. There's variety in everybody's tethered oral tissues. Variety. Everybody's tissues are going to be a little bit different. Here are some things that you might want to look for. Blanching is one of the biggest ones, right? So when you go to elevate or mobilize the tongue, so at the very bottom there, and I don't know if my little cursor will work, but maybe it does. Hopefully, you're able to see my little cursor scrolling it around. But at the very bottom there, you're going to see that frenum looks very white, right? I want you to imagine that there is an elastic band, like an exercise band. So you see those exercise bands at the gym, or you might have some in your home, and they are typically a color, right? And typically by strength, right? So like the black ones are like the most resistant. So you take that band, you grab it on two ends, and you pull it all the way through till you get some tension, right? So you have tension in your bands. These bands, now with all of this tension that is shaking you, because it's hard to hold them still when they hold that much tension, right? That's going to get to a little bit of the dysfunction of the tongue. But in between, that band is no longer all black. It's actually got white in it, right? So now you're seeing little bands of white. It's discoloring. That is blanching. So when you're seeing the frenum reaching that tension, I want you to think about that as like that's how it actually is. I'm grabbing at 2 points, I'm pulling, I'm getting the tension that is causing my body to have a visceral reaction to this tension. If you have an elastic band or an exercise band, try it. Okay. You're getting to the point where it's causing your body tension. Imagine that throughout the human body. All right. And the tie is going to look like a bunch of different things. You might see a shape that looks like the Eiffel Tower. So where along the alveolar ridge, it really is very wide, and then it arches up towards the tongue where it inserts wherever it's inserting, at the tip, below the tip, in the middle, wherever it's inserting. But it'll look kind of like the Eiffel Tower. So it'll have a very Eiffel Tower-like appearance. If there's anterior restriction, true ankyloglossia is what we would call that, because that's what they're teaching still in our dental courses and schools and universities and so forth. That's what you would put on a board exam as a tongue tie. True ankyloglossia, can't stick your tongue out, right? That butterfly lift or elevation in that bottom image is that butterfly lift or butterfly extension, where the cleft is there, where the restriction is pulling back on the tongue itself. And so when you do protrude the tongue, you're going to get the little bit of the clefting where it starts to part and it looks like an upside down heart, like the gentleman in the picture, the second picture from the top. So the second picture from the top. When you're looking at the lips and you're looking at the buccal or buccal frena, I never know which way to call it. I like buccal. Some people insist that it's buccal. I don't care what it is. When you're looking at these things, essentially you're looking for a similar thing, that tension, that blanching, that inability to really mobilize and engage, in some instances with the labial frenum, so the lips, maxillary or mandibular, and then the buccal or the buccal, they're going to be blanching, and sometimes you'll see a little bit of clefting in the gingiva, so you'll see that pull against the gingiva as well. Those are things that oftentimes, they'll do a quick snip, like your periodontist will do that, no problem. And nobody contests whether or not that was a buccal tie or we have to go see a myofunctional therapist. These are things that, yes, very commonly throughout the industry, right? So how do you know how to deal with it when you're looking at it and you suspect that there might be dysfunction and you're really just not sure, or you just really don't know how to go about this? If you do not pass go, if you don't know how to go about the next step. But I promise you, I'm going to ensure you what the next step is. Okay. You need to have a conversation with your patients. And I know first thing you'd be like, I don't even know what to say. Like, what am I supposed to say to them? People are looking at me like I'm crazy now, like I'm some money hungry provider because the New York Times said so. They said I was a money hungry provider. Well, actually, I think the very best way is to be as honest and upfront as possible. And to be honest and upfront, you have to actually know and understand the facts. I would be like, you know what? The research, it's a little shaky. My clinical experience, though, I can tell you that I've seen great functional outcomes. Why people aren't researching about the function, I don't know. I don't know. That's neither here nor there. And I would really love to get to the point that we are researching and really putting the emphasis on the function as the primary thing. So, from here, what I would say is that honestly, you as my patient, I'm going to explain it to you the best way I know how so that you can understand how the body works, how healing works, and how this procedure is going to be helpful as one tiny step in your functional outcomes. Okay. I love this picture. If you've listened to me lecture before, you may have seen this picture. This picture, I like it because it looks like this woman, like her arm is tied to her body. And this is my favorite analogy. Okay. So you take your arm, pretend that your arm is tethered to your body. And somebody comes along and it's like, hey, you've got an arm tie. Like you don't realize that your right arm there, like you're able to lift it up. You can, throw a ball, you can raise your hand, you can like really do stuff with that. You don't realize that the other arm you can't. Oh, well, never really paid attention to it. And I've got some mobility, like maybe you can bend at the elbow, but you can't really move beyond that because it looks like she has some elbow use, right? But she can't really bend beyond that. I'm not really bothered. Okay. Okay, fine. You're not bothered. It's not causing you a functional problem. That's fine. Totally fine. You can live the rest of your life like that. It's not going to be detrimental to you. This is not life or death. Okay. Then let's assume, oh, yes, this has been hindering me from being able to do, I don't know, simple task at home. Like I can't fold laundry because of this arm tie, and I need to fold laundry. That's a thing I need to be able to do. I need to be able to cook. I can't cook. I can't clean. I can't whatever because I don't have functional use of this arm. Awesome. Great. So here's what I'm going to do as a release provider. I'm just going to release it there and then you'll be fine. You'll do a couple of little exercises, YouTube them or something. You'll be fine. And no worries. You'll go on about your life, folding laundry, cooking meals, and so forth. Okay, release that. What are the odds? Let's assume this woman is 24. I don't care if she's 20. You can make her 19 if you want. What are the odds that after spending her whole life, 20, 24, however many years, her entirety of her life, without having access to her biceps or her triceps, okay, what are the odds that whatever exercises she's using on YouTube or wherever she's Googling and finding whatever, what are the odds that she's going to be able to have full functional use of that arm that got released? Very low, right? If you said very low, you're winning. You're a winner, okay? Because it's not going to happen. You're not going to get the outcomes that you want by just releasing the tissue. And then what's going to happen when you don't have that functional mobility? When you can't mobilize that arm, when you can't lift it up, you can't throw a ball, you can't do the things that you wanted to do because you don't have the muscular strength to engage that area of your body. Well, then when healing happens, because the body's intention is always primary healing, where it's putting two pieces back together. So even if you've removed the tissue between the torso and that arm, the upper arm, you're going to get a reattachment in that area. Okay. It's a misnomer, really, because if the frenum's been excised, has been removed, then it's not going to be a reattachment because it's not going to come back attached to your body. It's just going to be really poor wound healing. So it's going to happen where your arm now is tethered to your body in a new, more restrictive way. How do you think you would get to achieve those outcomes? Now, in the medical world, nobody would even think twice about this analogy. Duh, you send them to physical therapy. Send them to physical therapy beforehand because it's their arm, because there's a joint. There are important joints at both ends where we are trying to release. Of course, send them to PT before you do that release. And then you're going to PT after we do the surgery because that's what we do when we're doing a knee. Where you're going to get a knee replacement, you cannot get on the doctor's surgery schedule at all for any reason whatsoever unless you've started PT. If you haven't done the functional work, you are going to not be able to have functional use of your leg afterwards. You won't be able to bend at the knee. So, if we want you to get the good outcome, because we're doing whatever knee replacement, we're doing whatever procedure it is that we're doing it for a functional outcome. We have to send you to a functional provider. Hello, duh. It just like medicine wouldn't even think twice about that. It's just the way it has to be. But in dentistry, we seem to get very, very confused as to what the exact order of operations of things should be. If you want functional use of the middle, the posterior of the tongue, you're going to have to engage those muscles. You're going to have to engage in a therapeutic process to really start to mobilize, enhance the range, isolate the tongue from the jaw, from whatever compensatory function that was occurring prior. That way, when you do the release, and now we're trying to go for secondary intention healing, which is going to keep things apart and heal with a broader band in between these spaces. That way, the primary intention healing puts the floor of the mouth and the tongue, base of the tongue together, because that's the easiest way for the body to heal. Okay, primary. It just wants to do that. You get a cut on your hand. You don't look like the sum of all the cuts on your hands, I'm sure, right? The skin just boop, it just goes back together. Wants to make it like nothing ever happened. Secondary intention healing is like, I'm going to keep this split in my arm open. That way, we get as much of the scar tissue, we get some new skin, we get things to form in between. And then that's how we're patching me up. That's where we're going for. And you can't get that. You can't get that good healing unless you're able to mobilize. And you can't mobilize unless you've done the work beforehand. So myofunctional therapy should come before. If you're dealing with babies, because a lot of those articles were really about babies, you're not going to an IBCLC for them to diagnose a tongue tie and then send them to a dentist. You're going to an IBCLC to do some functional work, to get that latch assessed, you're going to a feeding therapist perhaps, because a lot of babies have difficulty even getting to, forget the breast, but getting to bottle feeding. Some of them are tube feeding. Like some of these babies are really not getting any functional sort of work going. So they might be seeing a feeding therapist. So if you're seeing a feeding therapist, it's to work through some of the functional issues. There's dysfunction there. Once you've started that process, you will be informed by your functional provider when you're ready. You're ready. Great. Go for the release now. Okay. And I know we always try to have these conversations within the field. For those of you who are already therapists or who are already in airway or doing releases, I know we have those conversations in the field about those poor babies who are, losing weight and who are about to get like tube fed, like has to have like a gastric tube or whatever. Mm-mm-mm-mm. Let's not make the few the many. Okay. That's a big problem in this field. We make the very few the absolute many. That is the smaller portion of what we're actually seeing and what we actually get in our offices. Okay. So a lot of them can actually wait to do some functional work. Every child, every adult needs to do functional work first. Then you come back and you do the then you come back, you do the release, and then after that, you do more functional work. It's like PEMDAS. Anybody remember PEMDAS? This was like a big thing for me. It still is a big thing for me. Every now and then, the internet likes to challenge my age and my brain, and every now and then, you'll see a nice little like, "Can you solve this?" And they have this funny little formula there, and it's like x plus 3, in parentheses, squared minus 5, 2, whatever. And it's like, if you don't do it the correct way using the order of operations, you're going to get it wrong. Guess what? That's exactly what happens in tongue tied too. If you don't do it the correct way, you're going to get the poor outcome. It's not going to work the way you want it to work. So let's talk about what the correct order of operations should be, or how I see it and how we really should have responded to this article. The article should have really gotten a different response from the industry than it got. I'm very disappointed in everybody who responded in any sort of way that didn't reflect that function was the real outcome and functional providers should have been the focus. Okay. Here's the process: you need to have functional work and manual therapy. So, manual, like manually manipulative body work or manual therapy, cranial sacral therapist, not my first line. Osteopathy is my first line. So a DO, a doctor who does cranial osteopathy or traditional manually manipulative osteopathy, is my first line. A CST, cranial sacral therapist, you might see a pediatric chiropractor, a pediatric, or if you're an adult, it doesn't have to be pediatric, but a chiropractor or a physical therapist. So those are your manual therapists. They will get in with hands, and the even better outcomes come when it's intraoral. When they're doing intraoral manual therapy, throw some gloves on, like get your fingers in there. It loosens everything up. You feel like butter afterwards. It's amazing. Absolutely amazing. They have to get that first. Okay. So functional work, working with a functional provider, getting some of the manual releases. It's like if you have a lot of tension, some people hold tension and they know it. They're like, oh, I hold all my tension here. I always get like this knot. And anytime I go for a massage, they have to work out this one knot in this one area here. Got it. Understood. Why do they have to keep working out this same knot? There's like this tension that is not just you holding stress, like your body doesn't take stress and just throw it to this one area. There's something else going on. And so, with all of the underlying dysfunction that may be contributing to a chain of you getting knots in that area, collaboratively could potentially help to work that out. Then, structural release would be next. So, you're going to do the work before, then the release, which is like a blip in time, mere minutes it takes. If you're doing some of these releases with some of the exceptional providers that are out here, the absolute minutes, okay, it takes to get these releases done. But the work you have to put in the weeks prior, and the work you have to put in the weeks to months after, that is where the change happens. That is where the good, juicy stuff is. That is where we should be devoting research. I don't want to see not one more thing about tongue ties. Like, it's a thing. We know people have ankylosing. We've known that forever. Let's start talking about function. Let's start talking about how function is going to be the way forward in order to validate the industry and to stop getting these PR nightmares and scares, and to stop scaring away providers from doing the good work that we know that they can do. Yes, a blip in time, that tongue tie release, but it could be the game changer for function. And that's only analyzed by, assessed, evaluated, whatever, by a functional provider and a manual therapist. Okay. What does that team look like when we're working with babies? Because it has to be a team, honey. It is not just one provider, okay? It's either lactation and a feeding therapist, then you have your body worker, and then you have a release provider. And in some instances, the best teams have a myofunctional therapist. Now, why, Carice? Like, you're not doing myofunctional therapy with the baby? No, you're not. But active wound management is actually really important alongside everything else that you're doing. So let's take somebody who just had a baby. And some of these people are going straight from the hospital, like they're taking their 1 or 2 day old baby straight to the dentist, didn't even try to do some functional work. Just in the hospital, we were told, and we're going straight here. But let's take somebody who just had a baby. whether it be 1 day, 1 week, 5 weeks, 6 months, you just had a baby. Okay. You are not familiar with going in mouths and doing all sorts of things. You're already hyper emotional. All right. There's a lot of hormones and hormone release involved, and a lot of different things that can really tip the scales on one way or another towards a psychotic, episode, or having an experience with not baby blues. Let's call it baby blues. Okay. You're already quite compromised at this point in time. You just go and you get a release. Now you get the release, baby's upset. Baby's probably a little bit more colicky, especially day 1, day 2. You're not familiar with these stretches. You're regretting everything you've ever done in your whole life. We don't know how we met you, so we don't know where you were when you were conceiving. Was this an intended pregnancy? Is this like the 4th try after a bunch of, failed pregnancies where it didn't come to term? Are we now at the end of what was a traumatic pregnancy, very high risk? Were you on bed rest? With my 4th, I was on bed rest for 20 weeks. Like, if you had told me that my kid had a tie and needed to have their tongue tie released, and it had to be a laser, and I would have to spend a couple $100, and then I have to get in their mouth and do, I would have had an emotional breakdown like you wouldn't believe. Like you wouldn't believe. And then, even for all that, I come from midwives. Like, my mother-in-law is a midwife. My mom is a former midwife. Then she was a labor and delivery nurse RN when she moved to America. And it was like 40, 50 years of her working in the field with babies, zero experience with tongue ties. Okay. Never looked in a baby's mouth for any sort of tongue tie. I don't think I would have had the support that I needed if I wanted to do that. So let's take a family who's never done anything like this before, who's already stressed that the breastfeeding relationship isn't working out. We don't know what happened with conception. We don't know what happened with birth. We don't know what happened during pregnancy. We don't know what stresses and pressures are already on this family and what expectations have not been met up to this point. And we don't know how they're going to react after all this is done, to now have to multiple times a day get in baby's mouth and do the stretch appropriately, because if they don't, now the weight of the world is on them, that this surgery that they just had their newborn baby do, this surgery might fail, and it is all on the parent. 100%. You don't do the active wound management, you don't do the stretches, you don't do this, you don't do it right, it's going to reattach, and it's on you. Oh, that seems really rational, to just get these people into our office and to just release them, because there's no social, emotional, like physical kinds of fallbacks or fallouts because of that, right? There's a whole lot. There's actually research about that, about how traumatic going through tongue tie release procedures for new parents can be. They may not have the support of their loved ones. They may not have the support within their own house. There might be parents conflicting on how they take care of this matter. So I think the myofunctional therapist, all this was coming back around to the myofunctional therapist, so that you understand where we fit. I think the role of the myofunctional therapist, and I've been that role, and I proudly stand in that role, where I work with the parents beforehand. I want you to get in here. Here's how you're going to hold. You're going to lift. Can you get on either side of that frenum? You see that frenum? Here's what we're going to do. We're going to take it easy, mom. It's okay. Baby's going to cry. Baby doesn't like fingers in the mouth. Okay. Watch. I'm going to start to put one finger there. Baby doesn't like it. Baby doesn't like it. All right. Look, I'm holding. I'm holding. We're counting. We're doing it. We're doing it. Awesome. Great. We did it. Baby's crying. You can hold baby. You can hug baby. You can love baby. And you see, it was traumatic for baby for a blip in time. It was traumatic for you in a blip in time, but there's no wound there yet. There's no wound there yet. You haven't done the release yet, and baby doesn't like it. But here's what you're going to do. You're going to practice. You're going to get in enough time doing this again and again and again with your baby, that now baby's a little bit more comfortable with it. You're more comfortable with it. Everybody kind of understands that now this is just a part of our new normal. So now when there is a wound, you're not as frazzled by it. You feel more capable to manage it, and everybody knows we're going to get optimal outcomes. My release providers are more confident that they're going to get optimal outcomes. My parents are more confident that they're going to get optimal outcomes. There's no guesswork involved. Nobody feels like they are, in any sort of threat of, oh my gosh, if I don't do this, this, that, it's going to reattach. It's all on me. I don't know what to do. They're very supportive. I'm there to answer questions. If grandma doesn't like it and she wants to know why we're doing this and she has questions, guess what? She's not going to be harassing. She's not going to be in the waiting room like harassing your front office staff. She's going to be asking your myofunctional therapist, "Oh, okay, here's what this is all about. Grandma, you want to get in here? Like let's do No, you don't want to touch your tongue. Okay, that's fine. That's fine, but I need you to support mom because this is what we're going to do. Or I need you to support dad because this is what we're going to do. Here's where we are." And so you're really managing a very, very critical role as a myofunctional therapist on a baby team. So I always put a myofunctional therapist on a baby team. And I guarantee you there's only about like 3 or 4 people who are actually filling that role globally. It's very, very sad. We need more support for these parents before the release procedures, and everybody else can do their roles. Like if you're working with their function, please just focus on the function. You have your myofunctional therapist who will be there to support and give the family that other sort of love and attention. And your release provider is just going to be able to stick to their schedule, get that release done, let them go, and trust that they have the support of the other providers behind them. Your body worker or manual therapist is going to be able to let go and release and whatever. And everybody's playing their own role. Okay. So that's why myofunctional therapist is there on the baby team. All right. Like, sue me. Sue me about it. I know that's going to wind up becoming a thing. Child. On the child team, it looks very similar, but also a little different. You want to have a speech language pathologist that you're very well networked with because a lot of these children do have some issues with their speech or, interpretation of speech, or there's a bunch of different things that can happen. Okay. Occupational therapy for any sort of sensory or, behavioral issues that might be also in the midst there. Your myofunctional therapist is going to work on the functional part of things or just supporting the family, depending on what that child's age is. All right. A body worker, manual therapist, and a release provider. Right. Last, our adult team looks a little smaller. More often than not, it's really just these mainstream three: the therapist, the body worker, and the release provider. Okay. So I know you're saying, but Carice, these teams look very large. That sounds very expensive. Like, I don't know what you think we're supposed to be doing here, but this don't sound like the route. This ain't it. It actually is. And when you are encountering people who have like barriers, whether it's finances or so forth, it's okay. Then you've got to prioritize. If they can't do all the things, okay, you can't do all the things. You need to double up and condense where you can. So you have to have the release provider on all the teams. You can't not have the release provider on all the teams. You need at least a release provider if it's actually a functionally restrictive tethered oral tissue that's going to be released. So you need to have the release provider. The functional provider, I think, is incredibly important too. If you have to take out the manual therapy, take out the manual therapy. If you have to, on the baby team, take out the myofunctional therapist, take out the myofunctional therapist. But you need the functional provider and the structural release provider. So at the very, very least, if we have to prioritize, let's get those two in and ensure that we're getting the outcomes that we want. Because when we just limit it to like, okay, I can't afford all of those, what's the most important one? Most important one is going to be function. It's not going to be the release. It's never going to be the release. Okay. That's never going to be the answer. So when you're confused, when in doubt, function. Function trumps all. Secondarily, we need a release provider. Okay. Awesome. Because what's at stake? All these things, just like I said before: social, emotional, psychological, physical. There's so much at stake for the parents. As a parent, I have 4 children. As a parent, let me tell you, 150% without a doubt, there is nothing that happens with my children that I don't think is my fault. It's not a personal flaw of mine. Okay. So that's a psychological thing. Whatever social, whatever the world is telling me about that and like how my kids are a reflection of me or what, like that's its own separate thing that I got to listen to. And if everybody's saying that, oh, confirmation bias is a big thing too. So I'm going to stick a pin in that. But if everybody is saying, no, you shouldn't do this thing, it doesn't get good outcomes. Look at this New York Times article. You shouldn't do this thing. And then I go ahead and do it anyway. And then what if I don't get the outcomes that I wanted? And then what if I'm part of those people who just like completely destroyed my child? That's everything to me. I mean, just take me away. I couldn't live with myself at that point if that was the case. There's so much at stake. So much at stake. So we have to think about it much bigger than our egos as providers. Like, no, we're right. No, we're 100% in the wrong, 100% all the time. There's no standardization. There's very little correlation for just having a release and getting function just magically out of thin air. You have to have the two together. You have to have the two together. We need to start shifting the conversation to that direction. If we don't, our field is going to implode itself because of that resistance. Be wrong. It's okay to be wrong. I think we learn better when we're wrong. Be wrong. I would much rather the public have a better stream and flow of how they should navigate this. I would much rather that they're in a bubble of safety. That way, any future articles start coming out and they're like, "Ooh, look, these people got their stuff together. They understand how they're supposed to do this, what that sequence looks like, how it's supposed to flow." And we have people who are happy along the way to their journey to health. Okay. So we've got like 15 minutes left. Okay. My biggest thing is that you need to remember you have to set expectations. Otherwise, you're going to fall into many common pitfalls. You will have people who will be very upset, who will blame all of their outcomes on you, who will have just selective memory as to what it is that you said and didn't say, and so forth. If they don't understand 100% before anything happens first, what the expectations are. One of the biggest issues in the New York Times article was that one provider allegedly didn't even look to see the latch or whatever for the baby, didn't look at anything, saw the tie, sent them away. So the expectations that's in that parent's mind, if you're not even going to look, you see a tongue tie and you're like, this is it, this is the problem, this is it, and you just send them away. Not saying it happened, but that's how it was written. So you just send them away. The expectation that's there is that if I get this release, magically everything's going to be better. And I hope by now, if you learn nothing else, sitting here this whole 40, 50 minutes, that at least you've learned that's not true. You're not going to get any sort of functional outcome. That's just like me telling you, go buy a scratch off, you're guaranteed to win. Then when you don't win, guess who you're mad at? And how many people win? Very few. Okay. Very few. So while it's really nice on the internet to have those beautiful things that happen where, you're like, oh, you got it released and my nonverbal child started speaking immediately. That is wonderful. That is a blessing. There's a lot happening there that has nothing to do with like a little string of tissue being released. There's a lot happening there. That's a full on blessing. Okay. It doesn't happen for everybody. You're not going to get that outcome. Don't go in there hoping to win the lottery. And that's what I tell all of my patients actually. When I set the expectations, I set it all the way appropriately. Like, oh, what are you hoping to come from this? Oh man, I can't wait. I've been watching all these videos. I joined this Facebook group and they told me that I'm going to feel like so loose in between here. Da, 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 da. Okay, that's wonderful. I want that for you. I really want that for you. Don't expect any of it. Don't expect not one bit of it. Okay. That's like me going to go play the Powerball and expecting to win and being like, yay, I saw somebody won last time. They won the jackpot. So why can't I? I'm gonna win the jackpot too. I mean, it'd be great. It'd be great if I did, but what are the odds? Very, very, very small. So what should I go in expecting? that I have a chance to win. I have an opportunity to maybe be in that small percentage. And if it doesn't happen, that's okay. Fall back. Fall back onto your functional provider, fall back onto your functional therapist who's going to be able to help you now get closer to getting there because it's a work in progress. So you have to set the expectations. Make sure you're having real, authentic conversations with these people and letting them know what the timeline looks like. In my program, here's what the timelines look like, or here's what I typically estimate. Okay. 3 to 4 weeks prior, you need to start your myofunctional therapy. I, I mean, I don't care what it looks like. Again, I don't know how many times to say that. I don't care what it looks like. We need to start working before you do the release. So even if you are true ankylosing here, you're like, I can't get my tongue to do anything. That's cool. We're gonna do some myofunctional therapy. We for sure are, because there are things that I could get you to do intraorally. Hmm. Hmm. There are things that you can do. So 3 to 4 weeks prior. Okay. And I do some myofascial release. So that kind of actually does help too. But 3 to 4 weeks prior, we're starting functional work. Then you'll get the release. I see everybody within 24 hours. I allow a little bit of grace for 48 hours, but at least within 24 hours because I need to know that you're on the right track. A lot of people get the release, they feel terrible afterwards. Oh, oh, I can't, I don't want to, I don't want to move it, or oh, this is as much as it'll go. And like, no, get that tongue moving. Let's go. Let's go. So I try to make sure that we are on the right track. We get on the right track. I know that you're healing. You have all of your post procedural active wound management instructions and so forth. I'm going to leave you alone for a week. That week, continue on as you've been instructed. And immediately after that week, when we see each other again, we are right back into it. It's like boot camp, right back into function. Because while that tongue is still healing, we're going to start getting those functional gains. That way, I can maximize our active wound management as much as possible. So then we resume myofunctional therapy, and that can take however long myofunctional therapy takes for you. Okay. It's not, I'm not giving you, oh, it's just a couple of weeks before, a couple of weeks after. No, you want function, you want outcomes. You tell me right now, if you were to fall and break your leg, how long will it take to fully recover and for that bone to fuse back? Oh, you don't have an answer? You don't know? How long would your doctor say? They would give you a range? Great, here's my range. It could take you another 6 months, it could take you a year. I don't know. All right. We're going to resume myofunctional therapy until we get to the end goal. Don't treat myofunctional therapy like it's supposed to be some like, cookie cutter, like check off a box thing. It's not. So, however seriously you would take getting functional outcomes or getting goals or healing or whatever from an MD, a physician, take it from me just as seriously. Okay. And that's the real goal. We're overcoming these obstacles. I know one of the reasons why I decided to talk about tongue tie is that somebody had asked for it specifically, saying, what happens when people like drop out of the program or whatever, like they start with you, they get the release and then they disappear. Honestly, honestly, I think that conversation starts prior to you ever accepting their payment or taking them on as a client. That conversation starts first. I'm incredibly transparent. I'm going to tell you that you're not going to get the outcomes that you think you're going to get. 9 times out of 10, I'm 100% right. And it's probably not 9 times out of 10, but most of the times, people might be like, "Oh, I felt really loose," and then the next day, it got super tight and I didn't like it, and then you came and you did your myofascial release and that helped a bit, and I'm going to go see my body worker tomorrow and I'm doing my exercises, and then it gets better and it gets better and it gets better and it gets better. But I'm going to be transparent. You're not going to whatever you think is going to happen as a result of this, cosmetic procedure, because that's what it is. It's a cosmetic procedure. Whatever you think is going to happen, that's not what's going to happen. It's a lie. It's a lie. Don't let the devil fool you. Be as transparent as possible. Once you're transparent, they kind of understand, ooh, like she mean business. She's like, I'm not going to get this outcome. What is this crazy lady? What is this crazy lady? But they really don't go anywhere after that. They come back and they see me. I've not had somebody who I'm transparent and honest with not understand that they need to come back because what they think is going to happen isn't going to happen. They appreciate the honesty. We're in a world full of glitz and glam. You go on social media, everybody has a beautiful life. Everybody has like all this wonderful stuff going on. There's so many smoke and mirrors. It's hard to navigate. Nothing's better than honesty. I think that's the biggest winner in this whole process. Don't rush the process at all. Don't rush it for them. Don't rush it like, oh no, I've got to get back to school at such and such time. What's so very interesting is that I had a celebrity client once that I didn't even realize was a celebrity client, and they were rushing the process and they were stressing me out. And I didn't even realize that this was a person who maybe I should have been a little bit more lenient with. But no, I was very much like, you're not going to get the outcomes that you want because you're trying to do this like 1 week before you go to college, and then you go to college and you're like, no, you don't want to see me via Zoom because you'll be on campus. Like that's crazy. Like your tongue is going to be re-restricted. I'll see you in the summer when you're back for your second round. Don't rush the process, okay? Don't rush the process. Reaffirm the process is actually what you should do. Continue. So, I see you, you're healing. It looks like you're healing okay. We could do better with this healing. Even if they're healing great, okay? We could do better with this healing. We could do a lot better. I think there's more gains for us to get. And if we don't get those gains, you're going to be in a worse off position. So, when I see you next time, here's what we're working on. There you go. You already feel, "Ooh, wow, I didn't, get what I'm supposed to get out of this yet? Alright, there's still more work to do." They're not going nowhere. They're not going anywhere. They're not gonna drop out, and if they do drop out, it's not on you. That's not on you, that's on them. I tell all my patients. My husband actually walked out the other day. We have, like, a joint office space where my office space is over here and his is, like, over there on the other side. And, I had a patient who logged in, albeit late, but logged in, and the nerve, it was a telehealth patient, so he logged in and had the nerve to sit in front of me and be like, "Oh, I didn't do the exercises, I just feel like, blah, blah, blah." It was just a whole bunch of excuses, a whole bunch of excuses. And I don't do excuses. So like the way I reacted to that was more of like a visceral reaction. And it just like, it scared my husband. He was like, "I don't even know why you're that angry at this man and why you came off like that." I didn't realize that I was coming off like that. But at the end of that, it was really essentially me just affirming that, look, it's not my muscles. I don't, what happens to you is not what's going to happen to me. I'm going to sleep well tonight. I have no OSA. I'm going to be fine. My tongue works great. I'm going to be fine. So you're not doing me a favor by doing your exercises. If you don't do your exercises, I'm good. You do your exercises for you, your muscles, your results, your outcomes. Now, if you're committed, I'm committed and I'm down for you. And we're going to do this until we get to the end. But if you're not committed, bye. I don't have time. I don't have time for that. There's a bunch of other people who would love to work with me who are going to commit. And so we want to keep those people. Those are the people you want to keep around. All right. So when they drop out, it's not on you. So I know that that's what this whole thing was supposed to lead to, like what to do. When they drop out, let them go. Let them go. They weren't committed. All right. So, what did we learn today as I wrap up in these nice little 2 minutes? We learned that definitely the field is messy. Airway is messy. Sleep is messy. There's a whole lot of people who aren't doing things in correct processes. There are people who are doing things in what they think is the correct process, and they're absolutely wrong in what their order of operations are. We really need to get on one page, on one accord. We need to be standardized so that we can legitimize the field because right now it is hella illegitimate. The most illegitimate field or thing ever in the world. Okay. There's a whole lot of yoga and Pilates that's got more validity than myofunctional therapy, dental sleep medicine, and airway. All right. We've got to come together because once we do, it's going to just take a weight off of the public and people will fall in line. We are at like a head. So when you look at who you think like the heroes or the big names, yes, I use the quotes, the big names in airway are, I want you to go look at their social media followings. The biggest social media followings, it's 40, 30, 40,000 people. Go look at people who do anything else. Ayurveda, like you look at Wim Hof. Wim Hof has 3.5 million people following him. He does breath work that is supposedly supposed to cure cancer. Okay? He does breath work that cures cancer. And here we are sitting around trying to argue the validity of like myofunctional therapy and Buteyko. I mean, nobody even cares enough to partake in these conversations with us. So, it's important that we start to meld and mesh our communication and our systems and our processes so that we can be better for the public. We show up better. I guarantee you, we're going to have a spearhead. We're going to have a spearhead of growth like you cannot believe. Okay. Two, we've also learned that we can establish a clearer public message. That way we get optimal outcomes. So it's about function. It's about function. It's about function. It's about function. Stop talking about the tongue tie. Who cares about the tongue tie? I don't care who your release provider is. Like these are not the things that are important. It's about function first and foremost. Okay. Lastly, Lastly, let's chat. Okay. I have to remember that I have to do this slide at the end of everything. All right. If you guys have any questions, feel free to send me questions. If you're watching on Facebook, LinkedIn, YouTube, hi, so happy to see you. Please leave your questions or schedule a chat with me. Schedule a chat with me at any point in time. I'm happy to talk about whatever you want to talk about. But if you're trying to get to the next level, and you haven't chatted with me, you need to do so. Okay. So do so now, and I'll see you guys again next week for the next live. Bye, guys.